So Protocol V came out of the question. We know that anti-VEGF therapy has clearly been established as first-line therapy for center-involved DME, or diabetic macular edema, in patients who have some visual impairment from their macular edema. But all the clinical studies have been done looking at eyes with vision of 20/32 or worse. And the question came up, should we be starting anti-VEGF therapy immediately when we see eyes with better vision? Is it worth the potential invasive injections that are given chronically over the course of years? So again, we took eyes with center-involved diabetic macular edema, but that had good vision, 20/25 or better, and randomized them to 3 initial treatment strategies. One group started immediate anti-VEGF as soon as they came into the study, and we used aflibercept. One group got laser to start with, and one group got just observation. We just watched them and waited. And the laser and observation group eyes were treated with anti-VEGF if the vision started to drop over the course of the study. I think one thing that's very important to understand about Protocol V is that this was not a test of monotherapies. This was not observation or nothing. This was really observation with anti-VEGF built in as a safety net if the eye started to lose vision. Our main finding was that at 2 years, that there was no significant difference in rates of 5-letter or more vision loss or 1 line or more of vision loss between the eyes that were treated with immediate aflibercept, observation, or laser treatment. And so what this tells us is that there is a window where these eyes that start out with a very good vision, despite having center-involved DME, may not need immediate anti-VEGF. You have the luxury of waiting and watching them and really treating just if the vision starts to drop. What do we do with eyes that have good vision but have non-center involved diabetic macular edema? And actually for many of us these days, we're very comfortable just waiting and watching those eyes because typically the diabetic macular edema doesn't affect vision until it starts to involve the center of the macula. And many of these eyes actually will resolve on their own without treatment. My advice for the treating retinal physician is first and foremost, always treat the individual that's sitting in front of you. And our clinical trials offer guidelines across groups of patients, but there may be characteristics in one patient or another that are going to drive your treatment decisions. I think for diabetic patients in particular, I always start with the foundation of recommending good systemic control. So making sure that if they haven't already, they're optimizing their blood sugar, their high blood pressure, their cholesterol parameters. Given those things, I think Protocol V offers us really at the conclusion that observation is a very reasonable treatment strategy for many of these eyes with center-involved DME, but that have good vision. As long as you're watching them carefully, following them closely, and you're treating them if the vision starts to drop.